First of all, I want to welcome everyone to the session 2 of AW Week 2024, titled Endoscopic Tissue Resection Mastery and Troubleshooting. And this is a question and answer session. And we are truly honored to have Dr. Kevin Benmuller with us today, who absolutely does not need any introduction, and whose ingenuity and global vision for our field moved gastroenterology forward in the past few decades. I don't know who did more for the field that you did. And we're, no pun intended, we're in awe of you. Also, of course, with us, our IWE group with Dr. Mary Lee Krinsky and Dr. Phoenix Nguyen. My name is Sonia Riker, and our goal for today was to do this very informally. This is an hour that we get to ask the master how to do things, and maybe not try to emulate it, but maybe try to approach it as close as we can. So the first thing, I'm having a bit of a hard time maximizing my slides, but let me just stop sharing for a bit and just share it again. So the first, so our goal was to essentially show you, here we go, show you the cases and ask you, just had my slides moving, but they're not moving now. Christian, you have my slides, right? It's kind of funny how we test them right before, and they work perfectly fine. And now let's see, let me try one more time. Yes, here we go. So this is the pictures. This is the referral. This is the outside referral for this polyp. And this is the endoscopic view of an NBI view of kind of a representative images, and NBI view of that broader nodule. And the question is, what would you do? And Christian, Uzma is trying to log in. If you please, we forwarded her the link, but she might need it one more time. She just texted us.
Okay, do you want me to email her? Because I'm monitoring the participant window and I do not see anyone trying to get in quite yet.
Right, if you guys forward it to her.
I can send it to her right now.
Okay, that sounds good. So Dr. Benmuller, what would your plan be for that? And
well, I think the very first is we have to start with just the fundamentals here, which is diagnosis. So before we start talking a little bit about the therapy, we want to be confident that whatever therapy we're recommending for the patient is likely to be curative. So the way I start when I talk to my patients is I say, because the patients come to me with the expectation that I can remove their lesion endoscopically. And I know that they will be disappointed if after I evaluate the lesion and I see stigmata of an invasive malignancy, that I'm going to back away and I'm going to recommend surgery. So I prepare them for that potential disappointment that this may not be an appropriate lesion for endoscopic resection, whatever method you use. So I think it's very important to, emphasize the need to spend the proper time with diagnosis. And our optics today are so phenomenal that we can really extract the information that we need to have a good prediction of our ability to cure a lesion with endoscopic resections because it's about the cure, right? So this is not palliation so that the patient maybe doesn't bleed or there's a blockage, obstruction. This is about cure. And part of that also is the need to be sure that the patient will be compliant with follow-up. So if we're going to embark on endoscopic resection, we need to be confident that that patient will be returning for a follow-up, let's say in 6 months, at the latest 1 year, to verify that what we did was indeed curative. So if I could just start with that, because I think those are things that just, we jump into the fun stuff, which is, resection, but really this is about good medicine. So let's start with diagnosis now. So you're all familiar with the Paris classification, and that's an important classification, I think, because we need to speak the same language. Unfortunately, in the past, there have been all sorts of terms that get thrown around, and it gets very problematic. For example, when I get a referral from another doctor and he writes or she writes, it's sessile or polypoid or depressed, whatever. That I don't know what that means. So the Paris classification ensures that we're all speaking the same language, but we have to understand what the terminology means with the Paris classification. So if we say 2A, we need to understand what 2A is, or 1S, what 1S is. And it so happens now, as I look at these pictures, I can tell you we're dealing with a 1S 2A lesion. But before we get into pit patterns and all that kind of stuff, well, I think the first thing is just to say, the basics is this something that we could potentially cure endoscopically? And so we want to look for stigmata or any signs that there may be an invasive malignancy. And the things that I look for immediately are, firstly, ulceration. If I see any obvious ulceration, that's automatically what we call a Paris 3 type, right? It's excavated. That's an ulcer by definition. So I'll look for that. If I see any obvious excavation. Now, depression's a different story. There's a lot of things that can cause depression. If it was biopsied previously, sometimes you'll see that. So that's different. That's in the Paris 2 classification. But if you're talking about a 3 with ulceration, well, that's already a no-fly sign. It's like, hands off. If you see spontaneous bleeding before you even touch the lesion and you see it oozing, that should raise a red flag. And then with our wonderful optics that we have, then we can sort of zoom in and we can look for other features suggesting an invasive malignancy. So that's where we're looking at the Kudo type 5, and you can see, irregular pit pattern, loss of features, right? It's really the loss of the pit pattern that I'm looking for. Not so much, I don't get all tied, this is a Kudo 3S or 3L or so, whether the pits are tubular or they're branched. I really don't care about that because it's not going to make that much difference, right? We're talking about a minimal difference in the risk of an invasive malignancy. But if you see a loss of pit pattern, areas of amorphology, of featureless, then that would be an alarm sign. Okay, so that's the Kudo 5. And then you're looking at the vascular pattern too, and you're looking for these really chaotic looking, crazy chaotic vessels. And or you're looking for dropout of vessels as well. So that, and there's various extra classifications for the vascular pattern if you use NBI like you're using here. So you may use the Nice classification. And really, basically, in my mind, there's so many classifications. So maybe in the future with AI, that's where I see AI could be wonderful. It just like pops up for you all the classifications and a prediction of what the likely type is, right? So is this Sato, or named after these endoscopists, type 2B, whatever. I just want to know, is this likely to be invasive malignancy? Okay, so I'm sorry to spend so much time on this because you're anxious to get into the resection.
No. We actually, this is in my list of questions that I prepared. That's what I wanted to ask you.
Oh.
Or like what, for example, but before I go to the next question, I see Uzma is here, and I want to introduce her really quick because I know she has a limited time with us, and exactly like you described, she's in between cases. We're very honored to have our esteemed guest and a friend and collaborator, Uzma Siddiqui, who is the head of CERT, Center for Endoscopic Research and Therapeutics at the University of Chicago, and a co-founder and co-president of Women in Endoscopy. And we collaborated together for more years than we want to discuss here. Thank you so much for joining us today. And we're just talking about everything polyps, what to do. And we just started.
Thank you for having me. Ken, I'm sure we can get into it further, but you know, as good as our intentions are at predicting polyp type, is there malignancy? We're just not perfect, sadly.
No, of course.
That is the
We're always
question.
going to give the patient then the benefit of the doubt. So I think if, you know, it's sort of borderline, well, then you could say, well, if actually EMR was first described not as a therapeutic procedure, but really as a diagnostic procedure, and the Japanese described it as big particle biopsy. So they took out big pieces really so that they could provide the pathologist with a specimen to determine the actual depth of invasion. So I agree. If there's no clear features like the ulceration and is bleeding or whatever, where you say, oh, this is an invasive malignancy. And you could, by the way, if you have a mini probe, you could also use that with EUS. But yes, you're going to give the patient the benefit of the doubt, because the other way to look at this is, I think if you're skilled and you do, you know, your complication rates are low, you could argue for just resecting it, and then the pathologist will give you the final answer. But I will tell you, if you embark on resection of this lesion here, there's going to be some risk here. So, you know, you want to be sure that if you're going to put the patient at the risk of perforation, I just might remind the audience that, you see, the problem with perforation is not so much really what happens after the perforation in terms of you have to admit the patient and, you know, maybe you have to vent them and maybe they're going to get peritonitis and so forth. And maybe they're going to need surgery. Well, yes, that's obviously a concern with perforation. But I'll tell you what my concern is. My concern is that you're going to get peritoneal seeding of this lesion. You know, it's been my pet peeve about, you know, when we endoscopists start saying, oh, we'll take out GIST tumors. You know, we can do this. Well, yeah, if you do this, you better be sure you're getting that GIST tumor out on block and with the capsule intact, because if you disrupt that capsule, you know, you may be seeding. So one of the things, my soapbox mantras is, we cannot risk that what we do, it potentially leaves the patient worse off. And seeding of a even if it's precancerous, but if you seed these cells, and I just mentioned this because that's the origin of why I eliminated submucosal injection. I just couldn't understand. I mean, for me, you stick a needle in there and you inject, aren't you seeding these dysplastic cells? And I realized there's no proof one way or the other, but that's what started my thinking about this.
I was going to say also, my soapbox is to get endoscopists to stop manipulating the polyp unless they're taking the whole thing out. Because when you have a really big polyp that, you know, half of it's been removed, it distorts the way that I interpret it when they're sent to me subsequently. So it can be very difficult to know, is it tacked down from fibrosis from prior manipulation, or is it potentially have submucosal invasion? And it's very hard to interpret. So
you just had a study, right, in GIE that just came out that showed that every with manipulation, you can tell better than I do about it, but basically the longer you wait, the worse it is, right?
And actually it just showed that all those manipulations, whether it's tattoo, partial resections, you know, those do cause fibrosis. And for every 2 weeks you wait, you're increasing the risk that we will have fibrosis on the subsequent endoscopic resection, and it will make the procedure that much harder in terms of how long it takes, in terms of potentially having any complications. And so we advocate trying to get the second colonoscopy done, you know, as quick as possible. And perhaps that's something to adjust in your own scheduling pattern. And I just was doing a case actually where they had tattooed into the base of the large polyp, but
God.
we happened to schedule it within 2-3 weeks of that prior colonoscopy, and it lifted very nicely actually, which is why I had time to make our session. I was really pleased with how well it lifted, and there was little, if any, fibrosis on the resection base. So I think there is something to be said that if it has been manipulated in the past and we know it, that we should try to get that patient in more quickly for the subsequent colonoscopy.
Another study, Uzma, I wanted to ask you about that was really interesting is the one you were involved in about competency of our advanced trainees when they finish the training. I looked at it and that was, I don't know what the word, I'm debating what the word should be for that, a little jarring, only like way less than half achieved competency for the polyp resection. What are we to do?
I mean, and Ken, you can also speak to this. I think
Yes.
it's also hard when we're training our advanced fellows because the polyps that are referred to our center are usually not the first time, you know, we're finding these large polyps. So they are very large, they're in a difficult location, and they've been manipulated in the past. So you're starting at a more difficult baseline for achieving resection. And for me, letting an advanced fellow do the whole EMR is probably one of the last things I do, because at the beginning of the year, I'm just looking at how they position the scope. Can they maintain a stable position? Then we go to injection. Then I see how they put the snare on it. We start with just basic polypectomy skills, which hopefully they've had in GI fellowship, but you'd be surprised. So you kind of have to adjust to what you get with the fellow. And it's probably towards the end of the year when they're even being kind of allowed to work on some of these bigger polyps in my practice. So I think it is a tough thing to get skilled at in 1 year. But, you know, I tell the fellows, even in my own practice across my career, the polyps that I'm taking out today are not anywhere near what I was taking out when I started almost 20 years ago. And you kind of work your way up as you gain more confidence in your skills.
Yeah, I think that, so my comment here, and we could really go way off on a tangent because I also have some views about now training. This is not your quote grandfather's advanced endoscopy anymore. I think 1 year to become a universal interventional endoscopist, right, where your EUS and ERCP are now, you know, should be interlinked, they should be combined during that training period for pancreatical biliary interventions. You know, our luminal interventions, you know, our third space, so the space, you know, the first space and the third space, and now we're even going to second space, right, outside of the GI tract. It's become so complex, and the skill sets needed to become expert at these is just enormous. And so I just question whether our current training paradigm structure is adequate for that. But that's a whole nother topic. I do want to say
we need another hour then.
Yeah,
I agree with you.
but here's, I think size matters for these polyps. And so we're a specialized service where we call it IES, Interventional Endoscopy Services. So we're separate from the GI lab where the community gastroenterologists do their procedures. And the question came up, should they be allowed to do EMR? And what I recommended, and this is in the, you know, for the credentialing of the doctors at the hospital, is to make size the threshold. So they can do EMR for lesions up to 2 centimeters in size. And if the lesion's larger than 2 centimeters, then those really should be sent to IS. So that's how we've kind of addressed that by size. But obviously location plays a role. Is that on the AO, on the IC valve, in the distal rectum? These are all additional factors.
Which is a great segue to the next question I wanted to ask, and that is also part of Uzma's work. So if we're getting all these polyps referred, what the information you would want to know, and that was another study, you were part of the group that was discussing that. What the information do you want from the referring physician? And how would you like, let's say, a photo documentation to be obtained? What are you looking for to be in that referral?
I mean, I wish we were better at getting more accurate information from some of our referring docs. But for me, the ideal referral would tell me exactly where the polyp is located. If there was a tattoo placed, tell me, is it 3 centimeters proximal or distal to the polyp? If there is a photograph taken, it would be nice if it was like the ones that you're showing on the screen here, where I see the entire polyp. Usually I get a piece of the polyp and not the entire picture. And a color picture, I think, is definitely better than what we get. Sometimes a faxed, very blurry black and white image where I really have no idea what I'm going into with the case. And that has some importance in terms of, you know, how long I want to plan that case to be, depending on the location and how big it is. And if it's been manipulated in the past, maybe I'll book that for 90 minutes, you know, versus something that's 30 minutes to an hour. And also just so I can adequately prepare the patient in terms of our discussion on my ability to resect this successfully. But we don't always get all those things. And I think also a lot of referrings underestimate or overestimate the size, and maybe aren't as attuned to just kind of looking behind the folds and giving that kind of extra information.
Dr. Binmiller, what if you would be obtaining photo documentation of this polyp? How many pictures would you take? Where would you take it? What would you focus on?
Well, I think this is a wonderful example where, first of all, you have an overview. So you really want to see the perimeter of the lesion. You want to know, for example, does this extend, you know, further behind that fold upstream? It doesn't appear to be the case, but it'd be nice to also have documentation of that. So you need sort of that overview of the lesion. And then, as I happen to see, you also have some more zoomed in images showing the pit pattern. I don't know that that is so critical, really, but for me, I really want to know the extent of the lesion. And the reason for this is because, again, size is the factor that determines how long these procedures take. For example, in the rectum, now I do ESD for all lesions in the rectum now. So I'm not doing any piecemeal resections in the rectum at all, because it's fast, relatively speaking, and I enjoy it. And I definitely, you know, value the ability to resect something unblocked in the rectum, because we know that the risk of malignant transformation is much higher in the rectum, and the risk of metastatic spread is much higher in the rectum. So rectal lesion, and there's more at stake, right? Because these patients may end up with a colostomy, you know, with an APR or something, if you're not able to curatively resect it. So I think a strong argument could be made for ESD in rectal lesions. But what I need to know for my schedulers and for my nurses is, how long is this going to take? Because if I've got a circumferential lesion in the rectum, or even hemicircumferential, that might take a good amount of time, right? So for the scheduling, we need to know that. Sometimes what I'll do is if I look at the images and I'm concerned about maybe there's an invasive component, then I'll bring the patient in for just diagnosis with EUS. You know, radial EUS is great in the rectum, right? And so I'll do that, and targeted biopsies. I very often, where the biopsies obtained by the referring doctor, that's another topic, you know, whether they should be getting the biopsies, because often that creates scarring. We know that. And in Japan, it actually, the referring endoscopists are discouraged from getting any biopsies, and maybe we should do the same. But regardless, if biopsies were obtained, and let's just say it showed high-grade dysplasia, but it's not uncommon that I'll find an area that clearly is cancer, right? And it just wasn't biopsied and properly appreciated, and I can target that, and then I'll get the answer back that this is frank cancer, invasive cancer. So I'll bring the patient just for a first session, which would be diagnosis. And again, you have to individualize, because some of our patients come from far away, so they will of course want one-stop shopping. Our solution there is that we'll explain, we want to make sure we get all the data, all the information, so that we can offer you the treatment that's optimal for you. So we recommend then that you plan on staying overnight in San Francisco. We have a nice Marriott right across the street from our hospital. And then we'll do the diagnostic part on day one. And then if it looks like this is a good candidate for endoscopic resection, ESD usually, then we'll do that on day two.
I see.
Along the same lines,
I just wanted to say, Ken, I agree with you on rectal polyps, and I've moved towards ESDing these. And I tend to just do a quick televisit ahead of time just to let them know, you know, once I get in there, I'll determine for sure how I'm going to take it out, or if it can come out, and that it may be a much longer procedure. And I usually book these like around noon and try to do it on a day I'm not on call and I don't have cases to follow. Because you never know till you get in there, is it going to take 1 or 2 hours, or sometimes 3? So everyone needs to be mentally prepared, you, the staff, and the patient.
You definitely don't want to book these as your
First case.
Yeah, exactly.
Your patients are all maybe waiting.
Yep.
Dr. Bindmiller and Uzma, I'm getting, am I correct if I'm getting this feeling that you're not because there's been this data on JNet, which we've been all using, that is really not performing as we would wish it to perform. What are your thoughts on that?
I'll let you start, Ken. I mean, all the classifications are as good as the scope you're using, and the prep, and you know, I feel like everything's up to a little bit of interpretation. And JNet is nice because it tries to simplify things for the endoscopist, but I mean, none of them are perfect. And I think where the Asian physicians, especially the Japanese, outdo us every time or outperform is just on their optical interpretation of lesions, which is why they don't rely on a biopsy.
Yeah, the sad part, that's very far from perfect as we're turning out.
But they also have higher series scopes, better
yeah.
optics than we do, so they can see the soul of a polyp versus we're just kind of skimming the surface sometimes.
Yeah.
in addition to the information that you want to gather from the referring physician, what about other concomitant illnesses they had? I had one referred recently and they didn't tell them, we didn't have the information. The patient had pancolitis, ulcerative colitis. How would that affect your approach?
Huge. I tell you, you're hitting a painful spot, because a few weeks ago, I had a patient with chronic ulcerative colitis. And she had so the problem there is that, you know, they have a lot of changes that are related to the chronic inflammation with elevated polypoid lesions. And so now in her rectum, they've been doing surveillance biopsies. So in the rectum, they got some biopsies and boom, dysplasia. So well, this is what we used to call DOM lesions. And so the patient was referred to me. And I don't want to get off in too much detail here, but you know what, it was advertised as being a fairly focal area. But then when I looked at this with our optics and underwater and everything, I realized this thing is far more extensive. It was 3/4 circumferential, where I could see, distinguish really normal mucosa from abnormal. And the truth is, with ulcerative colitis, you often, it's really, you can't distinguish what's dysplasia from just inflammatory, right? They look so similar endoscopically. Even the pathologists have a hard time with that differentiation. So I proceeded to do, and this was over 4 hours.
Oh,
Because it was so scarred. It was
yeah.
so scarred, was so difficult. And then at one point I perforated. And but this was high up in the rectum, so above the peritoneal reflection. And even though I closed it afterwards, she got peritonitis, and in the end it was all fine, and with antibiotics and so forth. I just want to mention this other aspect of this, because this was an important learning experience for me. So this took over 4 hours. I was exhausted afterwards, but here's the thing. That means the patient was under MAC anesthesia for 4 hours, and she aspirated during the procedure. And so we had a long discussion about how does this happen, this aspiration. I mean, she literally whited out her lung with the aspiration. It was horrible. So her complication was really more related to pulmonary when she was admitted after the procedure. And so what happens is, with the MAC, the propofol paralyzes the patient's ability to avoid micro aspirations. It's just a trickling of the saliva that accumulates in the mouth, and it gets down into the trachea, and usually it's of no consequence. But you may have noticed when you're doing colonoscopies that take a little bit longer, that the patients suddenly are coughing, or the anesthesiologist notes that they have to suction out the mouth, or they desaturate a bit. I don't know if you notice that. I've noticed it on and off, to the point that now when I get my consent, I tell the patients there's a risk of aspiration. And we now have a new rule in our department that if we think the procedure is going to take more than 2 hours, we just tube these patients. So that's sort of the consequence of this case. So I just want to share that with you, that this was a real wake-up call for me, that aspiration is a real risk for something that I thought would not be a risk. When you're doing colonoscopy, why would the patient aspirate, right? That would be with an upper procedure. No, these patients can aspirate because they're experiencing micro aspirations, and then it accumulates and it reaches a threshold where it can be significant.
Mary Lee, you bring such a great point. So just to finish this case, to let you know, and all of you made you nailed it, and I didn't give you no information about the patient. The patient actually has significant comorbidities, including rheumatological diseases and chronic kidney disease. And the first thing we discussed with her is a need to come back, and she said she absolutely did not want to do that, and she said that she would rather have a surgery and do it one time than to have to come back. And that's where we went with that. I want to before Uzma has to go, I just want to put one more case for her and Dr. Binmiller. Here's another one. It's at the appendix, and it goes into appendix. And these are the NBI images of that.
And
What would you do?
how healthy are they? And did you ever see the base of this polyp?
Haven't seen the base, and I'm thinking if I could share how healthy the patient is with you at this point. I don't think so. Just tell me what you would do if you don't know.
I mean, usually for me, for an appendiceal orifice polyp, I do like to go underwater. Here, Ken, I'm with you 100%. Go underwater, let it try to float up. But for me to say I got this polyp completely, I need to make sure at some point I have definitely seen the base of this. And if it's really growing deep into the
Deep.
appendiceal orifice itself, and the
Yeah.
patient's 40 healthy, I would probably tell them, look, you know, I can't guarantee 100% that I got every little bit of it, and potentially talk to surgery. Everyone, and especially my fellows, love bringing up the full thickness resection device all the time. It's very bulky, so if they have a really tight sigmoid, it's hard to get there. And B, there have been these reports of cutaneous fistulas developing that, for me, you know, make me really wary of the procedure, and C, appendicitis. So if I can avoid any kind of thermal cautery at the appendiceal orifice, I also try to avoid that. I had one delayed perf when I used to use APC a lot, and I really went to town on it, and the patient came back 36 hours later with a delayed perforation. So I try to avoid any thermal application as much as possible and go underwater, usually.
It looks like Mary Lee just texted me underwater with exclamation point. Dr. Bin Miller, is it underwater?
Well, yes, the advantage of underwater is that these lesions at the AO, sometimes they actually, I mean, this one's an obvious one, right? So you don't, it's what we call an innie, but you know, sometimes they're inside of the AO, and when you go underwater, the thing floats out and you see it. So I look at the AO and all of my patients, and it's not uncommon that I discover these, they're usually SSAs, and they're on the inside, they're innies. So this is a lesion that I think is amenable to resection with underwater EMR. However, we don't know whether it's extending into the appendix. It's really hard to evaluate for that. You can do EUS, but the EUS really is not going to allow you to know that. So the only way to know is to resect it, and then to look at the AO base and get biopsies from the AO base. It's usually a little bit into the lumen, right, of the appendix. Right. And if that's positive, then the patient goes for surgery, but the surgery is a cuff resection of the AO area. It's not what the surgeons will typically do for a lesion like this. They're going to do a segmental colectomy that will definitely sacrifice the IC valve. And I think the IC valve is one of the most amazing miracles of our Creator. A valve that literally is just one way and prevents all of those, you know, trillions of bacteria that live in the cecum, that's where the microbiome lives, and prevents those guys from refluxing back up into the small intestine. And I believe in preserving the IC valve whenever possible. So if you can preserve the IC valve by removing this and then having the surgeon, and we have a great collaboration with one of our surgeons, we've been doing this for many years now, who would just do a cuff resection around the AO with the appendectomy. And that way we have, you know, confirmation that it was curative. And I already can ensure the surgeon that this is not a lesion that's extending extensively, at least into the cecum.
That's a good point. That's a great point. And our surgeons work similarly and try to preserve the valve.
So and this might be a stupid question. When you guys do underwater EMR, do you ever do a submucosal injection?
Oh, I love to do submucosal injection all the time, except for maybe here, because usually at the AO and at the ampulla, it's kind of tacked down by the normal apparatus there, so it doesn't help as much. But I know, Ken, this goes against your teaching, but you know, when you resect it, I watched you live and I saw what I thought was a target sign. I know you assure me that I might be mistaken on that, but it makes me very nervous. So I still tend to do a submucosal injection, then I go underwater and I use suction, and I feel that for me works pretty well. But I know it's not standard.
Whatever works is what you should do. And,
Yeah.
you know, there's no dogma here. And I'm not like, gee, you have to always do this underwater. It's just a tool, like anything. It's like one of our instruments. So that's what I view the water method, is water submersion method. I will say, however, I mean, in terms of when I use submucosal injection, there are, for example, these lesions on the IC valve that then go over the, you know, the proximal fold to the IC valve. So the posterior lip. Okay,
Yeah.
so it dives down, and it's like a valley that goes to the cecum. And you know, even with the floating, you can't get that part of the polyp to float up into your snare. So for that, I'll inject in the back, not through the lesion, but in, you know, the cecal end, to raise that up, to bring it closer to me. So I think some mucosal injection can be useful so that you get better access to your lesion. The difference is, the only issue I have with some mucosal injection is injecting through the adenoma itself. So
And
I think if you can
it makes
avoid
a
that,
big-
you know, with ESD, I do some mucosal, of course, and
Right.
but you're doing it around the perimeter, and you're doing it underneath the lesion versus through the lesion.
So if I tell you
so
this
much
patient,
bigger too. Yeah, that's the
yeah,
one.
oh, sorry about that. So this patient is decompensated cirrhotic, and we can discuss why someone would do a colonoscopy in decompensated cirrhotic, who has ascites, and it's not a surgical candidate of any kind. It's actually, at that time, the patient was actively drinking. When we admitted him after removal of this, he had a withdrawal seizure. So this is not the ideal situation. And let's be honest, we did
This is
lift
where we
him.
have to be good doctors, right?
Yes,
Touch this lesion.
It
I mean,
is.
that would be a mistake, I think.
yeah. So going to the next one, and you probably wonder, why on earth would I be showing you this, right? Looks like nothing to worry about, right? With this kind of polyp. How would you guys remove it?
Maybe this would be a good case for a cold snare even.
Yes. So that's for sure. The thing that I wanted to bring up is that there's been increasing data lately, and I know at DDW there are going to be several large studies presenting, showing high recurrence numbers after cold EMR. What are your thoughts on that?
I was gonna say, I think whatever technique you use, you still have to be meticulous at looking at the resection site. So whatever hot, cold, if you're leaving pieces of tissue behind and not really interrogating your resection site, I think that does lead to recurrence. So obviously with the cold snares, they're smaller size, 9-10 millimeters. So you have to take more pieces. And I think we need more data, but I still think if you're meticulous and make sure you're getting the entire lesion and a little bit of normal tissue around it, we can keep those recurrence rates similar to hot. But Ken, I don't know your thoughts on that.
Well, I think the cold method, again, it's another tool that we have in our box. And it works marvelously for small polyps, less than a centimeter. So I remove all of my small polyps. Like I don't get referrals for these, of course, but if I do a resection of a large polyp and I happen to see some small polyps, you know, on my way in or out, then I take them out and I'll cold snare them. So I think it's a wonderful technique, makes total sense. The only issue that I sometimes have with cold snaring is I'm underwater. I'm pretty much underwater the whole time because I do my insertion underwater with water exchange. So you're going to get a little bit of bleeding always, and that clouds your view when you're underwater. So that's the only drawback of cold snaring for me when I do underwater. I will say that this idea of resecting larger lesions greater than a centimeter with cold snaring is, you're going the wrong direction of where we want to go. The whole benefit of underwater EMR is that you're getting significantly higher en bloc resection rates for larger polyps. That has been shown in every randomized trial. There have been seven with thousands and thousands of patients now. Every study without
And you did a meta-analysis of that for us. Yes.
But
Yeah.
You just published a meta-analysis of all of them for
No,
us.
I normally ignore meta-analyses. I mean, it's like, don't waste my time, please.
But
It's
that
just
was a
to
nice one.
publish something and
But
get.
you could
But
argue
I read this one
benign lesions you don't need en bloc.
of 7 randomized control trials. That's interesting.
But for benign lesions, I mean, you could argue you don't need en bloc. And I feel like cold snare EMR is kind of the intro EMR technique for people who are trying to work their way up a little bit. And I agree with you, over 2 centimeters, I'm gonna always do hot, but for a sessile serrated flat polyp that maybe is up to 2 centimeters, I think if you do a submucosal injection with dye so you see your borders and then cold snare it, I think for especially for the beginners and trainees, I think it's a great technique.
The reason I wanted to bring this case up is more of an illustration of what not to do. So this is the report for this one. It's very dramatic, but it was one of the most painful colons that I ever done. That took every possible effort to get to the cecum, to that polyp that we did, that required the rigidizing over tube and a single balloon endoscope that finally get to. And then we proceeded to do something not very smart. That is an unsuccessful submucosal injection that essentially buried that polyp and made it twice as hard to do it. And I think it's a good illustration that if we would have done it underwater, we would have been done minus all the time to get there. That's just the illustrative point of that.
I was gonna say also, yeah, if your position is unstable, you want it in as few pieces as possible. So
Yeah.
So that is a very good point. If it took me 2 hours to get there, I would try to just inject and do hot snare and get that one on block, solely for the reason that I don't have the stability to sit there and take smaller pieces.
So I just want to make the comment that if you're going to do code snaring of larger polyps, larger than a centimeter, the Japanese have shown very nicely that the depth of resection, the level of resection, is very shallow using code snare, much more shallow than with EMR. So I think those lesions should be injected. Then there you need to do that if you want to do code snaring of larger lesions.
I know Uzma has to go. Best of luck with your next case. And thank you so much for joining us.
Thanks for having me.
All right. We have a little bit more time still with Dr. Binmiller. Going to just a few more cases. This is the lesion in the rectum within probably within a centimeter or 2 from the dentate line. And it's biopsy proven low-grade carcinoid lesion.
Yes, I saw that right away too.
I knew you would.
Sometimes the local endoscopist will mistake this for a polyp and then resect this. And then, of course, the diagnosis of a net comes back and the margins are not clear, the deep margins. So these get sent to us for additional resection, which may require FTRD. So for such a lesion, I think FTRD might be a good option, but I just do ESD for this. But I do EOS first to be sure that this isn't one of these nets that's actually invading more deeply, because sometimes they are. If I don't see a submucosa, you know, the white between above the MP, then I'm not going to proceed. Again, because of the principle that whatever I do, I want it to be curative for the patient.
You must be clairvoyant. So I don't think we should have done the US, but there was nothing, at least I don't remember if we did or not. And we embarked on ESD. And it was at that ESD, as hard as we tried, we could not find the plane. And it was looked like it was in the muscle, or at least it was significant amount of fibrosis. We could not get it out, and we aborted. You just had a amazing case of intramuscular ESD for gastric lesion that was recently published. Could you comment, like, how do you do it? When do you do it?
Well,
Should
so-
we be doing it? That's
Well, one of
That's
the
kinda-
things, this gets into underwater ESD, because that's how I also do my ESDs underwater. When you do underwater ESD, you get the same floating effect, but now with the MP. And then you really see the distinction between the circular and the longitudinal layers. In the stomach, in fact, down in towards the antrum, you've got 3 layers. So you see that these are like, floors, and they are, they're separated from one another. And in fact, there's a little bit of connective tissue between them. One of the reasons why when you do submucosal injection, you may actually perforate is because you're actually lifting, for example, the circular muscle layer, because you got your needle between the circular and the longitudinal layer. And then you're injecting into the connective tissue between the circular and the longitudinal. And the longitudinal is always a wispier and thinner than the circular. The circular is your muscle layer, your real muscle layer. We know this also from poem, right? When you do your incision of the circular layer, it's nice and thick and bulky. And then the longitudinal is sort of wispy and very thinned out. So the bottom line here is that you actually can differentiate these layers, and you can be much more precise. And I would even argue that the serosa on the outside, that's also a layer that you can appreciate. And it's not like if you preserve the serosa, you understand that in the TNM classification, the serosa is an important component of whether it's T2 or T3. So T3 is outside of the serosa. There's a reason for that, because the serosa is a layer as well. So it's not like when you go through the longitudinal, the outermost muscle layer, you're staring at the gallbladder or the liver. You actually still have a layer there. So I think what we've learned now through what we call third space endoscopy, because this is still in third space, as in the second space would be outside the serosa, is that we can become more precise in differentiating these layers. So I think the attention that I had hoped to bring with Ed Despot was, you should pay attention to these layers. What does that mean? How does that translate? Well, I mean, we all know that the submucosa is where you have all the vessels, the lymph vessels, and the blood vessels. So anytime you have any kind of malignancy that's invading into the submucosa, the issue is whether you have metastatic spread. However, you're going to have situations where patients a poor surgical candidate, for example, or so, and you really can curatively resect lesions, even when that are invading deeply, up to the superficial circular. I call it superficial now. That's the circular muscle layer. That's the superficial muscle.
Yeah. Going to the next one, which is similar but more successful than the other one, with the ESD, and we close the defect. Do you close your defects? Should we be closing all of them? Should we be closing some of them? And how should we be doing that? And before we close,
I think no excuse not to close today because we have such amazing closure tools. They work so marvelously. Before we had the excuse, we only had clips. And I see that you use Apollo here, the overstitch to close this. That's time consuming, it's expensive, I mean, you could have closed that thing easily with some clips, I think. Because our clips, they have longer distance between the prongs, they rotate so nicely now, more precisely. They grab, we have different types of clips. We have the mantis type, which is where you can really dig in one prong onto one edge and then dig the other prong, sort of independent of one another. Truly independent of one another then would be the DAT clip tissue, approximation tissue. That's where you go in, it's like the twin grasper, and you just grab the one edge and grab it, and then you pull it over like a sheet to the opposite. And there you can really close much bigger defects. So, and then, there's X-Tac, of course, if you really.
I think that was X-Tac.
This is X-Tac? Okay.
Yeah.
Yeah. Well, doesn't look great. But you probably need to put some clips.
Yeah, that we did on top in the middle.
So yeah, X-Tac is just time consuming. It's sadly conceptually, it's nice, but from a practical standpoint, it's not.
Clips are better. I understand. How do you assess for deep mural injury after your resection?
How do I treat?
No, assess. What is your approach? How you assess for deep mural injury? The polyp base.
I always look at the polyp base, always, and I'm underwater, so I just get a beautiful view of the base, and I inspect it, and I, you're right. Maybe there are cases where I might have had a little bit of a target sign where you catch some of the circular. It's possible with scarring, right? Especially after a prior resection attempt or where tattoo was injected and we get scarring. It makes sense also that the longer you wait, the more scarred the tissue becomes. So I'm happy that Uzma published on this. And sadly, though, I think it's not going to change how our endoscopists in the community practice, because what I'm witnessing is that we're still seeing all these lesions. They get, failed attempted resections, their tattoo always underneath the lesion. Some are injecting with tattoo to lift. It's just incredible. So in a way, I'm disheartened that the message just doesn't get out there. And still a large number of patients just get sent to surgery. So it's just hard to change these patterns of practice. But in the end, I think that once you have a paper like Uzma's that actually then documents that this is, that can get translated into actual guidelines, so that if you do have a complication from the procedure and the doctor injected it before the tattoo got underneath the lesion, attempted the resection when really it wasn't appropriate, then, I think the only thing that changes practice patterns is the dollar sign, or the fear of litigation, and that's not the way we want medicine, but to evolve. But unfortunately, sometimes that's the only thing that changes practice patterns. All right, enough on that. I'll just say I always inspect the base very carefully, and as long as you don't have an obvious free perforation, I think you're fine. And then I always close the defect anyway, right? So now if there's any concern of a residual at the base, then I biopsy that, of course. And I do get biopsies from the margins. I don't do what's very commonly practiced now with this soft coag with your snare around the edges or so. I don't do any of that. I just very carefully inspect the margins. I do, when there's a question about where the perimeter of the lesion is, I'll make some little dots around the perimeter. That way I have an orientation. And then if I see the dots after the resection, then I might biopsy that area where I see the dot. Or I may trim that area with a small snare. So I don't do the coagulation of the margins.
And
In
if you're
the-
trimming, do you use a cold snare technique or a hot snare?
Oh, it's always hot snare. Cold snare I only use for small lesions that are under a centimeter. That's the only time I use it. And I have tried some of these otherwise very nice, fantastically engineered cold snares that work very, very well. But as soon as you're getting above a centimeter, trying to do, because I like to do on block, right? So then it gets the snare can get stuck. And then I've had instances where I can't open the snare again. I've had instances where you're forcefully trying to cut through, and these snares are designed to really cut through, and then the wire breaks, and then you got a loose wire. So all these things have happened to me, such that I now just don't even try to code snare anything that's larger. And like I said, I think that we're just going in the wrong direction when you're doing this little piecemeal. I mean, it's become crazy how you're just getting these tiny little pieces. Well, I'm not surprised that there's a high recurrence rate just from the
40,
piece.
more than
You're preaching to the
40%.
choir.
Yes, but Mary Lee actually had a great point. What are your thoughts on hybrid ESD with like sort of hybrid ESD, any of those hybrid techniques? Do they have a role?
With the hybrid has maybe only the potential advantage if you're having difficulty seating your snare around the perimeter for on block
Likely.
resection. You might consider that. The risk is that it's perforation.
And then when the 1 minute we have remaining, I just wanted to show this case. This is just, I think, summarizes every point you made. This was a true 2A lesion that was extensively biopsied at the outside. And as much as we worked on it, it came back with recurrence. And here's recurrence. How would you manage that?
Well, this is where sometimes underwater has been shown to be effective, capable, but it may not be when it's heavily scarred. And so this is where, again, in our toolbox, we do have something called the endorotor, which is basically a shaver, and it can shave off this area here of scar tissue, and it works great. So for these patients, heavily scarred, I can't do a resection, and ideally that should be an en bloc resection of whatever residual is there. Then I will use the endorotor, and it works just marvelously. Now I see your picture here that I guess you opted to do full thickness. I will tell you though that full thickness, this FTRD device does not work well with scarred lesions. You will
No.
be in trouble. And then you're going to end up, I have this, I don't know, maybe it's just the marketing that makes it sound so wonderful. I have had more problems with FTRD than successes. So I will only use it in a lesion that I know will easily, I can bring into the cap fully. And when they're scarred, you can't bring that in. So then you're going to end up with this clamp, the bear claw, in there in the tissue, and you're not going to have your full thickness specimen.
Right.
And then you're stuck with that thing there. So
True.
this could end up making your life much more difficult.
Yes, and it actually did. You know it all. Do you see pain after FTRD frequently?
I'm sorry, do I see what?
Pain, patients after FTRD develop pain post-procedure, almost
Yes.
white count elevation.
So painful. You don't know what you're grabbing around there, and then the nerves are on the serosa part. Yes, they have a lot of pain. I had one patient who insisted I had to remove it, so then I had to order that stupid device, to cut it. So,
Yeah. Well,
yeah.
that answers that, and thank you so much. I think we covered all our cases, and I'm sure we can talk to you for hours and hours on end. and we're learned so much, and thank you so much.
My pleasure, and look forward to doing this again. And congratulations on your meeting. That's fantastic. I'm just sorry that I can't be there in person when it takes place, but this is marvelous. Thank you.
Thank
so
you.
much, Ted. Have a wonderful week.
Thank you.